Tonight, we are talking about an issue that is literally a matter of life and death for many people. Prescription drugs, how we use them and how we abuse them. So stay tuned.
And on Stay Tuned, you drive the discussion. We bring local experts, journalists, and civic leaders together to have tough conversations for a stronger St. Louis. Tweet us your insights on tonight's topic, and you've got a seat at the table. With a few national experts and a panel of community members, this is the show bringing more light and less heat to the issues that matter. So stay tuned.
Well, let's start by defining the problem. Let's start by talking about what the problem of prescription drug abuse is and what prevention might look like with two gentlemen here at the table. I'll do introductions first. Matthew Ellis with Washington University School of Medicine and Daryl Hudson with the Brown School at Washington University. Both of you are epidemiologists. Thank you for being here and providing your expertise. I want to start very broadly. What do we know about why a person would try drugs? That sounds like an after-school question, but don't give me an after-school special answer if you can, I guess.
Sure. I think broadly people try drugs for a number of reasons. So a lot of it is peer influence. So if you're talking about youth, you're thinking about what your friends are doing oftentimes. Oftentimes there's also social context or neighborhoods that people live in. So what's freely available in that particular neighborhood? So before we started, we were talking about The Wire, which is this great treatment of urban poverty and drug abuse in the United States. So a lot of it is around the resources that people have, the coping resources they have, the opportunities they have, and the lack thereof.
Yeah, because we're not just talking about youth tonight, for sure.
Right.
Sure.
And I think with prescription drugs, what makes it such a difficult problem is that if you look at the populations we've looked at that are opiate addicts, over half of these people started initially with a prescription from their doctor or dentist to treat pain. And that includes a broad spectrum of people from 18 to 75. And so it's not just a youth problem now. You have this prescription opioid problem that runs the gamut from young people all the way to old people. And in fact, we see this problem from old people to middle-aged people to young people. And that makes it a very difficult problem, A, to diagnose and track, but also to treat, because you have to incorporate all these factors of, instead of just a young population that you're targeting, you have to think about older people that are in pain versus abuse. So,
and how our bodies react differently at different ages, I'm sure.
Right, and pain is one of the most difficult things medically. I'm not an MD, but MDs will tell you that pain is one of those things that's very personal. And there's, like you said, there's a wide range, and what is painful to one person may not be as painful to another. We were talking before the set again, we still
use that scale, that smiley face, frowny face scale is the best measurement we have for pain. And then, again, what makes it so difficult is, when does someone cross the line from treating pain to addiction? Because there's a number of people we talk to that say, well, I use opiates more than I should, but I do it because I need to treat my pain. I need it to feel normal. Well, those people are using 20 pills a day. So is that actually treating pain, or is that actually an addiction? It's a very fine line between the two.
Yeah, sure.
So what do we, how does what we know about why help us try to come up with some way to prevent it?
Well, I think one of the big things now is better education for doctors in medical school in terms of pain management. I was at a conference last week, and someone showed a statistic that doctors receive about, on average, 7 hours of pain management training, whereas veterinarians receive 40 hours of training on pain management. And there's this...
Say that again. How many hours does a doctor get for pain management
On
training?
average, it's about 7 hours in medical school versus about 40 hours for veterinarians. Granted, it's a different species, but you can see that there's, and the people we talk to, there's people that say, a large group that say, well, I was undertreated for pain, and so I went out and sought medications on my own. Right. You have this group over here that says, well, I was overtreated for pain, so I use my medications more frequently. And because pain's so difficult to measure, It's very difficult for doctors to know how to properly prescribe pain.
Right.
But because they have a patient that they say is in pain, you can't necessarily neglect that.
Sure.
You have to work with that.
Yeah, not to mention there's racial, ethnic, and gender differences in how pain manifests, not just manifests, but how people think about pain in different populations. So people can come into the same examination room and just have a different characteristic, be a woman versus being a man, and the physician interacting with them will make assumptions about how much pain they might be in or
Right,
what they need. Yeah.
Tolerance especially.
So one person who needed 20 pills, let's just use that example, might put them down when the problem goes away, and then another person might not. Why do different people react differently? Why does one make that jump to abuse and maybe the other doesn't?
Sure, I think it's a difficult question. It's very individual. I think part of it is individual susceptibility, underlying genetics, family history, and things like that that make everyone function differently. So it's that environmental interaction as well.
Yeah, and I think for a lot of people, they don't see it as abuse. They see it as, they just continue on this line where they are, in their heads, they're treating themselves for pain, and their treatment, they build a tolerance, and so they need more pills to treat their pain, and so it gradually builds up. But a lot of people don't see themselves as addicts until much further down the road, until they're like, well, my use is out of control. I'm taking so many pills a day, something's wrong. And then if you stop them, we have lots of people who their doctor will think they're taking too many pills and cut them off. Well, then they go into withdrawals, and they go to the streets to get pills in order just to keep from feeling terrible from those withdrawals.
It's so debilitating, and then they're thinking about the cost of it as well, and then people start to go into other drugs like heroin that are cheaper than prescription drugs.
They are cheaper.
And that obviously wreck your body.
Right.
You said, okay, so doctors get 7 hours of this kind of training. Who else should be getting training, or should anyone else be kind of in the loop there when it comes to education of this problem?
Well, I think that pharmaceutical companies have some responsibility in terms of training people on the medications that they have available. But I think doctors, in terms of also with the education, there's also this fear of if I overprescribed, I could be investigated by the DEA, or if I underprescribe, am I really treating my patients? And so there's education, but there's also the fact that pain is so hard to measure, as we brought up earlier, that there really doesn't seem to be a very good solution. We have these PMP programs that are used to track how much someone's being prescribed, and it's supposed to curb doctor shopping, but in the state of Missouri, we're the only state in the entire country that doesn't have a PMP program.
That's excellent foreshadowing. We're going to talk more about that later in the show. One thing I want to talk to you about real quick, though, is we started out the conversation talking about the youth. I remember the DARE program.
Yeah, sure.
So did that help? Is that still going on?
It's interesting. Everyone knows about DARE. It was pretty much ubiquitous. Everyone knows about DARE.
Great publicity.
Right. But as far as we know, the results are pretty inconclusive. And we can think about a number of reasons why it didn't work. Were they reaching the right audience? Was the messaging right? So I think from a broader prevention standpoint, we have to think very carefully about what works. So we have some good models now of campaigns at national and certainly at local levels that have worked, like Truth Campaign around anti-smoking. So that was a campaign that they did a lot of market testing, market research, segmented the audience in a very savvy way. And we've seen some results in Truth Campaign reducing initiation of smoking.
Daryl and Matthew, thank you both for your time. Stick around if you would. We'll talk to you again at the end of the show. We appreciate your time, both from Washington University. Okay, now let's go to Margie Enright, who's going to introduce us to an ongoing effort to take back some of the drugs that are in our lives.
It wasn't until he heard a knock on his door Friday morning that St. Raymond resident Doug Hofffelder really considered that bottle of expired medication in the back of his cabinet.
Like kids get into people's medicine closets.
They do, yes, absolutely, yes.
Unfortunately, I don't know if people understand what to do with, especially with medication disposal. They have these pills sitting around, they're just not sure what to do with them. They don't want to just toss them in the trash or dump them out of the sink or in the toilet.
We can just take it and get rid of it for you.
As part of the DEA's National Prescription Drug Take Back Initiative, local organizations, including St. Louis College of Pharmacy and St. Louis Area Agency on Aging, spent this weekend educating the community about proper medication disposal.
We're just kind of getting it out into the community that we are doing drug take back. They can bring their pill bottles that have drugs that they're no longer using anymore or expired drugs, just anything that can prevent drug abuse, little kids from getting hold on these drugs or even from the drugs getting into the environment.
The take-back included drop-off sites all over the region, including this one at the O'Fallon Park YMCA. These efforts expanded beyond community centers, pharmacies, and police stations to also include outreach to those who might have greater challenges making it to the drop-off sites, including seniors. Why is it so important to get these medications out of the home and into the right hands? A big reason is keeping them out of the wrong hands.
It's much like having the liquor cabinet at home. It becomes an attractive nuisance. And what we know from surveys that are done is that for teenagers in particular, the first source of initiation when it comes to narcotics like that are prescription drugs, and the most common source for those prescription drugs is friends and family, and that translates to the medicine chest.
I've seen several issues with kids getting hold of their parents' medications. Sometimes they may think it's something, a juicy drug or that they want to get a hold of. It's kind of a slippery slope. Once you get started, it's really, really hard to stop.
Studies show that 12 to 17-year-olds abuse prescription drugs more than ecstasy, heroin, crack cocaine, and methamphetamines combined.
The demographic profile of prescription drug abusers is white middle class. There it is. So anyone who thinks because I don't live in a certain neighborhood, my kids are not as likely is fooling themselves. Every high school in America is dealing with this issue. These pills are available. They serve a good purpose. They're necessary for the treatment of pain, so they're produced. But we also have, an opiate is an opiate, whether it's heroin or a morphine injectable or an oxycodone tablet.
This take-back journey that began in community-wide collection bins and cabinets all over the region ultimately ends at the incinerator. DEA agents collected and disposed of 9 tons of medication in the St. Louis metro region alone. But officials say you don't need an event to turn in unused or expired meds. There are drop-off sites all over the region. For a list of local permanent collection sites, visit meddisposal.org. For Stay Tuned, I'm Margie Enright.
Thanks, Margie. Okay, so one of the white coats you saw knocking on doors just now was Dr. Amy Tiemeyer from the St. Louis College of Pharmacy. Thanks for being here. We're talking about what's in our medicine cabinet. Why is what we just saw important?
Well, especially in that population, we were going to senior living facilities. And if you think about our senior population, especially in those locations, they have limited mobility many times. They have limited access to transportation. So even for them just to participate in a national take-back day like the DEA does, they don't have access to those things. It's very hard to get to one of those locations. The other thing is seniors many times have lots of medication changes. So they go into the hospital, medications get changed, something isn't working, their doctor makes a change. In general, they have a lot of medication changes. And so there's many times medications sitting around that they no longer need to use, but it's very easy to get confused about those medications. So let's say the doctor increased the dose of a medication. If they don't get rid of that old bottle, they could be taking more of a dose than they really need. They could accidentally overdose, get things mixed up. How many little round white pills are there?
Right.
So it's really an issue for the senior population. And again, from the perspective of diversion that we're focusing on tonight, that if they have family members or friends, grandchildren coming in, if there's anything that they're not using that could be abused or misused, we want to get that out of the home so that it's not an issue and they're not having to worry about that.
Do you find that, do you tell the people that you're training that it's actually important to do what we just saw there?
Absolutely. The students that you saw in the video are some of my students, and we talk about how important it is to educate patients about proper medication disposal, making sure you're not taking expired medicines, and to really be careful with what's around the house. Also, from a safety perspective, thinking about children. Kids love things that rattle and shake, and that's what medicines are in a bottle. They rattle and shake, and so you even see many accidental poisonings of children because of medications that are left out. Sometimes they are needed, but many times if they're not, it's just best to get rid of them.
I think the agent said treat your medicine cabinet like it's your liquor cabinet.
Exactly, right. So if you think about your liquor cabinet, you don't want your little kids getting into it and accidentally tasting it. In those smaller bodies, alcohol and medicines are much more toxic at lower levels, so so a little bit can do a lot of harm. If you think about your teenagers and young adults who are kind of in that exploratory phase and maybe trying out some things maybe that they shouldn't, liquor, and again, medicines, we know that there's things called farming parties where they will take medicines out of the medicine cabinet, go to a party, dump them in a bowl, throw them back with some alcohol just to see what happens.
I'm gathering there's not a tractor and hay bales involved in this farm party you speak of.
No, farm as in pharmacy.
Got it.
So yeah.
Not to make light of a very serious
Right.
situation. I'm sure all the drugs, we want to take them all seriously. Are there some that are more dangerous, perhaps, or more addictive that we should particularly watch out for? Certainly
Anything that has that addictive quality to it. So narcotics, any kind of narcotic pain medicine like morphine, Percocet, Oxy, anything like that that's addictive. And then stimulants. We're seeing a lot more treatment of ADHD appropriately, but there's a lot more stimulants out there now that we're more aware of it. And we've got medications, so things like Ritalin and methylphenidate, those things are very addictive as well, and we want to be careful with those. And then some of our stimulants and some of our anti-anxiety meds, things like Xanax or maybe some sleep aids that, again, many times have very legitimate uses, but if we're not using them, can cause problems.
I think a lot of people would say, if I've got this prescription from my doctor, it's meant for good. How can it be bad? Is there a psychology there that's dangerous, or maybe even some chemical things we need to know about?
Well, certainly with narcotics, they affect a lot of different things in the brain. So they help with pain, but they also stimulate that part of the brain that makes us feel good and gives us some euphoria. With some of the other medications, again, a lot of it depends, like what they were talking about earlier. There's a lot that has to do with our genetics as with regards to how likely we are to get addicted to something. There's socioeconomic factors. There's lots of different things that play into whether or not something becomes addictive. And we even know that when patients are being treated for pain, if their pain is not being well controlled, we can see something that we call a pseudo-addiction, where if we just treat their pain properly, they'll be fine. But because they're in so much pain, they're doing some things that look like addictions. So they're increasing their dose to try and control their pain. And they might be trying to get more medicine before they're supposed to and things like that.
Okay, I know you guys can't get to everybody with the program that we just saw there. Tell us, what are the proper disposal methods?
Sure. So obviously the DEA has been hosting National Take Back Days twice a year, and those are great options. In the St. Louis area, we are very fortunate to have another option that's available pretty much every day of the year. These are medication disposal boxes that are in police precincts, and they are available anonymously and free. You can go and drop them off. There's 35 or so in the metro area that are taking back medications whenever you want to go in and drop them off, and then they dispose of them properly by incinerating them.
Can't I just dump them in my sink or flush them down the toilet or throw them in the garbage?
You could, and we hear that quite a bit, and that was really the old recommendations, and we're trying to re-educate people about that. We know, based on some AP studies in the past, that those things are starting to show up in our rivers and streams, and we are concerned that if we don't start to do something to change that trend, that those amounts will get higher and higher, and then we'll start to have more effects in our food chain and maybe even potentially to humans. And so we're really trying to say incineration is the best way to keep it even from getting into the water supply.
Dr. Amy Thiemeyer from the St. Louis College of Pharmacy, thank you for your time and your expertise.
Thank you.
We want to hear what you have to say about this topic as well. I know this is a very personal issue for a lot of folks, so find us online, #StayTunedSTL. In fact, I believe we can see a little bit of what you're already saying. So we know this, we've kind of alluded to it already tonight. We've done shows on it before with some of the guests at the table tonight, that this problem doesn't just stop. Oftentimes it leads to other bigger issues, if you want to say that. I don't know, characterizing one as bigger than the other might not be right. But let me do the introductions with the folks we're going to talk about this with. Dan Duncan, National Council on Alcoholism and Drug Abuse. Welcome back to the show. Also welcome back to CJ Strom, Bridgeway Behavioral Health, and Chad Sabora, the Missouri Network for Opiate Reform and Recovery. So I mentioned just a second ago, this can be personal. I just, if you don't mind, I just want to read something to get perhaps the perspective that we don't have here represented necessarily. So this is from a family member of mine. I won't say who or where they live, but this is a person who I love very much and is dealing with prescription drug abuse. And they wrote this on Facebook recently, and I want to just read a little piece of it and get your reaction to it. I worked my behind, we'll say, off harder than I've ever worked for anything else or anyone else. The lives of my wife and kids were background noises that my obsession ignored. I isolated myself from my friends, only seeing them or contacting them when I believed I could manipulate them into my service. So I want that person to know I love them very much. First, I just want to say that as well. But does that resonate with the folks that you guys help?
Sure. I mean, that's the story that we hear, all of us hear all the time. The addiction gradually takes over your life. It becomes the most important thing to you. Everything else falls by the wayside. And the person who's going through it hardly understands what's happening to themselves until they get to a point where they don't know which end is up. And hopefully that happens before they die and they can get some help, get some treatment. And, you know, I'm living proof that recovery is possible. I've been sober for 33 years. And so my drug of choice was alcohol, but I could have written that same thing.
And these prescription drugs don't stop necessarily with that.
No, I could have written the same thing. I don't have as much clean time as Dan, but I'm recovering from heroin addiction, and I could have written that too. Once you cross the line from abuse into addiction, your willpower is gone on opiates. And just the need to keep going drive you to isolation, to manipulation, to doing all the things that are written down there. It's a disease that takes control of your entire body and soul.
You know, I think that it's often stated within the programs of recovery or support groups, and what it's stated is that I ended up in places I said I'd never go, doing things I said I'd never do with people I said I'd never do them with. And the reality of it is that is a pretty common statement between people in recovery, because when this begins, no one considers what's going to happen, or they will use denial and state to themselves, this won't happen to me. And inevitably, if anybody knew the consequences of doing it, nobody would begin. None of us would have ever started engaging in some fun, some looking for experimentation, looking for another way to feel if we knew what the consequences were.
And prescription drugs are different than street drugs in that, you know, the perception is that it's from a doctor, it's safe, it's controlled. And so people just, as CJ said, they don't see that happening to themselves. You know, I'm stronger than that, I'm smarter than that, won't happen to me. It's just something that happens to other people, but in fact, it can happen to you, it can happen to your loved ones, it can happen to your kids. So we're all susceptible potentially. So the more people understand that and don't think that this is something that happens to the other guy or the people down the street, the better off we all are in terms of having a social approach to a problem that's becoming all too universal.
So where are we with this prescription drug problem, and where is it often leading? I think we have a stat, and someone mentioned it earlier, like half of all young people who injected heroin surveyed reported abusing prescription opioids before starting heroin.
I would say the number is higher than half.
I would agree.
Most of the heroin addicts that I work with, including myself from my experience, prescription painkillers led to my heroin addiction. There comes a point in time when your tolerance gets so high that the painkillers don't do it anymore, and it's becoming too expensive. So you switch to heroin.
Heroin's cheaper than the prescription
in the
drug.
beginning. Okay. In the beginning, heroin will be cheaper. In the end, it'll cost you everything. And so will prescription drugs, because as Dan said, you know, the perception is wrong, because we see all these deaths, and we're hearing about this from heroin, opiates, #1 leading cause of accidental death in America. Most of those, a lot of them are heroin, but a lot of those are contributed to prescription drugs. So the perception is wrong. They're not as safe just because a doctor writes your prescription. Any opiate will kill you, and any opiate can turn you into an addict.
You know, and we've seen something happen when this new class of painkillers came on in the early 90s. They were ostensibly going to be used for very serious pain issues for people, for instance, that had cancer that were terminal. But it evolved over a few-year period where the doctors were, you know, writing prescriptions with this stuff for everybody for any kind of pain, and that's what's happened. And so now we've got a situation where there's just tons and tons of these medications out there in the medicine cabinets, as your previous guest mentioned. People have access to them. They divert them. They're sold on the street. and kids are using them to get high. One thing that wasn't mentioned earlier is these drugs, as effective as they are in dealing with pain, they also make you feel really good because they're an opiate. And opiates are highly addictive, and it gets a grip on somebody really quick, Casey. And once it gets a grip in them, it changes, everything changes, and that's why they would become willing to switch to a drug like heroin, whereas prior they probably would have never considered doing something like that.
Once you get to the point when you're going through withdrawals from pain pills, the decision to switch from prescription opiates to heroin isn't even a cognitive thought. You just do it because your brain has basically been rewired by the drugs that it needs that to function. So you just keep going down this downward path of destruction and addiction.
And I think the reason for that is the way that it impacts the human brain. So what we're talking about is it impacts the pleasure-reward pathway inside the brain. And so what happens is that a person begins to use these. It could be for a legitimate pain reason. It could be a person's experimenting. But once that, for Chad's term, gets rewired, the purpose of use becomes avoidance of withdrawal symptoms. And so that's when you'll see an awful lot of people that will overdose. It really happens in three spots as it relates to heroin. One will be of a period of short abstinence, use the same amount, getting under the influence in a place that's unfamiliar to them, or a place where the drug that they get, the purity is unknown. So those are kind of three of the ways that folks overdose on heroin. But it's opiates and heroin act the same way in the brain as it relates to the pleasure-reward pathway.
What should the I don't want to say the rest of us because I think we've kind of established it affects a lot more people than we realize. But what those who maybe not be struggling with this particular problem, what should we be doing?
Well, one thing I think that we have to do is we have to have a couple things. One is docs have got to take a good hard look at how much of the stuff they're prescribing and back away from it. The other thing is we need it was mentioned earlier, a prescription drug monitoring program in the state of Missouri. We are the only state in the country that doesn't have this. And it makes sense to have it. And that every other state in the country has seen fit and seen the wisdom to do this, but we haven't, really is attributable to one senator on the western side of the state, Senator Rob Schaaf, who opposes it in his mind as a staunch libertarian. It somehow violates people's personal freedoms. So he's filibustered against it. And he was rather revealing in making the statement that these kids that are overdosing and dying are cleaning up the gene pool, which I think is a heinous statement. And I repeat it any chance I get because I want people to understand what we're up against with this one senator. He's a renegade, and we have to find a way to get this guy to stand down because this is something that would help. It's a database that physicians and pharmacists would have access to just for controlled substances. So that we can curtail doctor shopping, because this is where doctors are not at fault. People come in that become addicted. They're very good at manipulating doctors. They've got all kinds of stories, and they go from doctor to doctor. How's the doctor supposed to know that this guy was just at another doctor getting the same pills? You know.
One thing,
So no, that's excellent foreshadowing. And again, we're going to go out.
One thing CJ and I were discussing is that one of the biggest messages we have to get to the people that aren't affected by this is not a criminal justice matter. This is a public health issue. Absolutely. It needs to be treated as such. This is a public health crisis. We have a lot of focus now, as we've spoken about harm reduction, to keep people alive, and also creating more pathways to treatment, which is going to change things and save people's lives. But the biggest thing we're facing now is stigma, and people looking at this as a crime matter when it's not.
Thank you, gentlemen. I appreciate your expertise and your insights. Thanks. Stay with us. Let's stick with the theme of the personal impact of this topic tonight and what's at stake here. Welcome back to the show, Joe Richardson. Joe, let's just jump right in. I want you to tell me about your son.
My son was 20 years old, and he passed away the 12th of August, 2012. And we got a call about 10 months before that he had got hooked on heroin. And it started out, we saw a change in him when he started drinking in high school. And then he had evolved into trying marijuana. And then that led to the heroin. And before that heroin started, he had had a couple of wrecks. And he was on some heavy painkillers. And I think that has a little bit to do with him leading into the heroin part.
I mean, I got to believe there was never a moment where you ever thought my son and heroin would be in the same sentence.
No, we were just your average family. I've never been involved with drugs, never took drugs. And yes, I was one of those parents that said, oh, that kid would never do that. That's not going to happen.
So what do you tell people? Because I know you have picked up this banner and you're out there talking to people openly. What's your message?
I would say that you need to educate yourself as parents and as a community, and you need to realize this could happen to you. I'm living proof, and it will destroy a family. It tears you down. And it can happen to anybody. It can happen anywhere. This is everywhere in our metropolis area here. It's in every city and town. I get calls from people all over that I've known through the years, and they want us to come and speak at their schools.
Was there, can you tell me more about his story? I mean, was there a point when you, for lack of a better phrase, figured out what was going on and there was some progress made there, or did this all come as a complete surprise when he passed away?
This was a complete surprise early, but he had called and told us. He had gotten arrested and said, hey, I need to tell you something. I'm hooked on heroin and I'm in trouble. And I said, well, we love you, we'll get you help. And we kind of went from there. But before that, we never saw anything. But there's so many red flags. I can look back now and go down the line, and there's so many red flags.
Tell us what those are. What do you wish you knew then that you know now?
Well, the missing money more frequently than not. Going out with different friends, a revolving door of different friends. You know, you don't change friends like my son was changing friends. It would be a different friend each week. Hygiene, sleeping more than regular, non-interested, schoolwork, calling off from work, telling us he didn't have to work, he's supposed to be at work, he's not there.
Tell me more about what you're doing now and what you're advocating for.
I am co-founder of the Awaken Project, and we do drug awareness and music advocacy in schools and do school assemblies. And I partnered up with Jeff Mozingo, who owns Mozingo Music, and he approached me after I introduced him and my son, and they really hit it off. My son was very talented. He could play 7 instruments.
Wow.
And he was a good athlete. Everybody loved BJ. He was a class clown. I didn't meet anybody that didn't like him. And he was just a wonderful person, loving, caring, and introduced Jeff, and they hit it off well. And 2 months later was when we lost my son. So he had been trying to get into schools, and it's been tough because they want to cut the music program, they don't have the budget. So he approached me and said, hey, what do you think about doing this? Are you ready to speak about this? And I said, absolutely. I wanted to get out and let people know, and this is therapy for me, and I wanted to let people know it could happen to you, what the dangers are, and just educate. So we took this and ran with it, and we have done a whole lot of good here lately, and we're getting bigger and bigger all the time. We're getting more corporate sponsors, and we're getting into schools regularly now.
So what do you want us to do? What should we be doing? How do we prevent this as you see it?
I think we need to educate ourselves. We need to look into the NCADA, check their website. You can go to our website, awakenproject.org. There's all kinds of information out there. Please don't bury your head in the sand. This problem is not going away. It's been here for the last 10 years. It's really gotten worse.
We're going to talk more just a little bit about something called Narcan, and we'll kind of get into more what that is, but essentially it's a drug that can keep a person from overdosing when that process starts. I just want to get your opinion on that real quick, because right now it's not legally available, widely available legally.
Well, first of all, I'd like to throw a big thanks out to Chad Sabora for getting this steamrolling, and I think that it's good. You know, if you can save these kids that are dying, which my own son was saved by this Narcan in my mom and dad's house. I mean, I think this is a good way to go, but there's so much more to it. The long-term effects and what's to come down the road is far more greater than just saving the kid's life. But in order to get the kid cured and help them, they have to save them first.
Joe Richardson, thank you for sharing your story, and stick around if you would. We'll talk to you some more. Thank you very much.
Thank you, Casey.
Let's go back to social media and see what you're saying. So in putting together tonight's show, we heard from more than a couple of people that we needed to talk to the school district at Maplewood Richmond Heights. So we have the superintendent here with us, Karen Hall. What is it that you're doing on this topic at Maplewood Richmond Heights schools?
Well, thank you, Casey, and thank you for inviting me. And I'm so happy to talk about the innovative work that we have done with our older students, and to be more specific, it's our alternative learners. In a really therapeutic environment, we have created these pathways to, in essence, peel away different layers in order for them to be successful to get their high school diploma. So essentially what we've done, we have partnered with the Children's Service Fund, the different agencies, and through developing clear pathways, we know which way we can support the students. That's peeling away those different layers in order for them to be successful, so they can be the scholars that we know that they are.
To explain what you mean by that, when you say these pathways?
Well, what we discovered with our students in this particular environment, they had a hard time succeeding like in a small environment because they had so many competing issues. I mean, we knew that there was substance abuse issues, there were self-harm issues, and we couldn't address that alone. You know, we needed outside agencies to support us in order for us to do our job, and that is to educate the students.
So what are you, I mean, if this is an area where you feel like you have to focus like this, what are you seeing when it comes to prescription drug abuse and then the things we've talked about tonight that it can unfortunately lead to as well?
Absolutely. Well, in the past 10 years, we have seen an uptick of the use of prescription drugs. And it is a concern, but our issue is how do we respond to that in conjunction with being preventive, but being more systemic and effective in addressing the issues and communicating and partnering with parents. So in the past 2 years, we've gotten better with that, and as I said before, working with the outside agencies is very helpful for us because there's only so much that a public school can do. And what we are experienced in how to support young people. So having that collective impact approach, partnering with outside agencies is critical. We couldn't do it any other way.
So what's the attitude that you're seeing? If we have something now called Farm Party, which is not that new, what is the attitude towards this issue, towards prescription drugs specifically? Are kids unafraid of the consequences?
Well, if you have someone participating in an activity like that, they're a risk taker.
Yeah.
And what we see ourselves as educators at the district, we see our responsibility is to educate as much as we possibly can in terms of the consequences. And then be very clear, if we still have risk-taking behavior, what do we do in order to put them right on track again and not say, oh, well, they have a problem, but no, how can we support, coalesce, bring in the family, provide them counseling, and then continue with their education? Because at MRH, Maplewood Richmond Heights School District, we believe in personalized service. And even on the other end of the spectrum, when we have children that are at risk, we want to figure out how can we best help them achieve.
Do you see anything in what you've done and where you've had success that could be more broadly applied? Lessons we could take outside of the school?
Oh, absolutely. Again, that is the community approach because it's not isolated to our school district. And that's critical for schools, that you have to partner with the community. You need to know about the other agencies out there to support families. Because if you don't support the families, then a lot of the work just goes to the wayside that you put towards the student. You need to expand that a little further in order to help them.
Do you see, do the issues you deal with at school reflect the community? Does the community reflect the school? I mean, can we kind of read one from the other here?
Well, and you've heard from the other speakers today, it's prevalent in society, and it's unrealistic to say that it's not going to come into the schools, because kids in one way or another are going to have exposure to this, and we have to be real. We have to be honest about what's going on, and as it's appropriate, for me, like developmentally appropriate, we need to address these issues with our young people.
Are you making progress?
I think we are now. The past 2 years, I see more of a systemic approach to supporting our young people when they're in crisis.
And what do they say back to you? Do you have any encouragement for us from anything you've heard from the kids?
You know, actually, yes. Recently, I read an essay from a young person from our alternative school, and they were so grateful now that they had this opportunity to focus on their education, and now they have a great sense of self-worth and hope.
Karen Hall, Superintendent, Maplewood Richmond Heights School District, thanks for your time and thanks for the work that you're doing. We appreciate it.
Thank you, Casey.
Let's go back to social media. Let's talk about if we can maybe legislate or prosecute our way out of this problem. I think we know the answer is that's not the only way, but I want to get to that part of it with State Representative Holly Rader, a Republican from Sikeston, Missouri, representing the Boot Heel.
That's right.
And also Scott Collier with the DEA.
Yes.
Thanks for being here and bringing your expertise. Nice to see you on the show. And Dr. Heidi Miller, welcome back to the show. Family Care Health Centers. Okay, so let me ask real specifically, because a couple of things we've kind of touched on throughout the night. What is PDMP? We talked about that just a little bit ago.
PDMP stands for Prescription Drug Monitoring Program, and it's essentially a database that would be managed by the state, where pharmacies, after filling prescriptions, dump the data into a central repository, and then physicians would have an opportunity to access that data in an effort to determine if perhaps that new patient sitting across from them asking for painkillers has been to see, 5, 6, 7 other doctors in the past 5 days seeking the same things.
Doctor shopping.
Doctor shopping, in other words, yes.
We heard that we're the only state that doesn't have this in the country. Is that accurate?
That is accurate. Puerto Rico and Guam have this.
So do you support a measure like this?
Very much so, very much so. And we have pushed it several years. And this year, we got it back out of the House again, and it has stalled in the Senate. And it is because, of course, which has already been mentioned tonight, is Dr. Schaaf, he truly doesn't believe in this and feels it's a privacy issue, and so that's where our holdup is at this time.
And we've also had some personal experience. A lot of people come to the table. Do you care to share any of that?
Absolutely. My daughter, she's 28 now. At 17, she was waiting tables at a local restaurant and making hundreds of dollars in tips a week. An excellent student, been in church all of her life, and she cut her thumb opening a bag of okra, and went to the emergency room, had her thumb stitched up, and left with a script of Lorcets. When she finished with the script of Lorcets, she just started buying them at work from different people that she knew, and now we're 11 years into this through many rehabs. And just as they've spoke tonight about heroin, down in the Boot Heel, meth is more prevalent. And so when she couldn't afford the prescription pills anymore because she was taking over 30 a day, she moved on to meth. And that is something that we still struggle with today. It's been a cycle. And so, I spoke on the House floor about this when we were debating the bill, and I told my story because I grew up in drug addiction. My family, my cousin died from prescription pain abuse, pill abuse, and been in legal and illegal drugs throughout my whole life. I was raised very poor. My daughter, however, was not. I kept my children from that. And this spans all social classes. And so it's very important that we start talking about this. And after I spoke on the floor, when I sat down, I had representative after representative come up to me and say, thank you for being so candid. Thank you for talking about this, and tell me their stories. And one gentleman said, Holly, I have never shared this with anyone because I've been so ashamed. and embarrassed that this is in my family and worried about the political repercussions. But that's it. We need to talk about this because this is everywhere. And just as we've heard tonight, our kids are facing this every day. And if we don't start talking about it and not being ashamed of it, but looking for that solution, and this prescription drug monitoring program is a preventative. It's something that can help keep the pills off the street so we don't have as many kids getting addicted before they get into trouble with the police and everything else. This is a preventative measure.
Dr. Miller, we've heard a lot said about the doctor's responsibility. Give us the doctor's perspective on this issue.
So the prescription drug monitoring program is an absolute must. I'll give you an example. So if I send in 10 prescriptions for a very complicated patient to one pharmacy, that pharmacist is going to do a med interaction check to make sure it's like a double wave of safety that I haven't mistakenly given 2 meds of the same class. This is the standard for good medical care. But what if one doctor is sending in a prescription to one pharmacist and another doctor is sending in a prescription to another pharmacist? As of now, the lack of communication between pharmacies is akin to the dawn of email, when organizations would have email like with
internal servers?
Internal servers, right. So you could just email the people within your business or the people within your school, but you certainly couldn't span from one organization to another. That is how backward we are in lacking this drug monitoring program. And as of now, we have to work piecemeal with little pieces of data to try to identify patients who are double dipping or need help for abuse. And my nurse and I end up turning into like a private investigator trying to figure out how to help our patients because the facts aren't adding up. And if they go to Walgreens, the Walgreens is very good at scanning all the Walgreens to see if that patient has had another narcotic prescription filled at another Walgreens. But they don't know what was filled at CVS or one of the other 200 pharmacies in the region. Sometimes we look at claims data. So for cyber access, we can figure out, well, if someone used their insurance to pay for 2 different narcotic prescriptions from 2 different doctors going to 2 different pharmacies, we can see that data. But that's only if they use their insurance. That's only with particular insurances. We're picking up the phone, calling the pharmacy down the street saying, have you taken care of my patient? Have you prescribed any medicine? Because I'm really scared that the medicine I'm prescribing is going to interact. So the time and resources that are wasted in trying to keep our patients safe is definitely behind the times.
Do guys like you want this?
We would love to have access, absolutely. It would be a good tool for us, but most importantly, it'd be a great tool for physicians.
And that's what I meant. Do you want to see this in place? Not
Absolutely, absolutely. We see it more as a preventative measure, because if somebody is doctor shopping and they're seeing 4 or 5 doctors getting oxycodone, hydrocodone, whatever it is, and the doctor has a simple 21st century tool, and I loved what you were saying, because we aren't living in the 19th century. This is the 21st century. There is no excuse for us not having a system that doctors can use to improve health care. That's it. That is the bottom line. And this will save lives. It will allow physicians to have a private conversation with that individual in the privacy of their office to address Senator Schaaf's concerns.
Yeah, I didn't
about the issue.
And so I'll ask you the question. Does along the lines of his concerns, do you want to get your hands on something like this?
It could be useful for us, but quite frankly, at DEA, we're not meaning to sound uncaring, we're not interested in the individual drug seeker or drug user. We are much more interested in finding the purveyor, whether it's the street dealer of heroin or that small sliver of physicians who are out there who have simply turned their medical practice into the modern day equivalent of a crack house and selling prescriptions for no medical use for $300 to $500 a pop, as we've seen across the country, as we have seen in Missouri, and just making it a profit-making machine. A tool such as this would help us find those high-volume physicians. But let me be clear, high volume is not necessarily indicative of bad medicine. Oncologists are going to be high-volume prescribers. But what we're looking for are the practitioners who are issuing prescriptions outside the normal course of medical practice, sort of just in a cash for drugs transaction.
We've heard a lot of people saying this problem is getting worse. Where does this rank in terms of the priorities of the DEA?
Well, it's quite high. When we look at the various surveys that are done by University of Michigan and others, we know that there are approximately, 7 million prescription drug abusers as opposed to roughly 400,000 heroin abusers. There's your problem. There are more people who abuse pharmaceutical drugs in the United States, mostly narcotics, than there are abusers of heroin, cocaine, crack, methamphetamine combined.
What do you wish lawmakers were doing? Is there a role that you think, are there tools that you would like to have that you don't?
In Missouri, prescription drug monitoring program, and that is a state system. It doesn't need to be a federal system. We have the tools that we need to do our job, which is to interdict drug traffickers. But we need to see some of these new tools come into effect so that physicians, can play their role and deliver good quality health care and prevent some of these issues from becoming a law enforcement problem.
Is pain management intimidating for young new doctors?
Pain management is not, because in the 1990s there was this burst of advocacy for treating chronic pain. And there was evidence that patients were being undertreated. So in the 1990s, pain became an extra vital sign. So physicians are trained in how to assess pain, how to treat pain. But I think I personally had about 2 hours of training in substance abuse in medical school. I guess I should have gone to veterinary school. So that lack of training is a big problem. And so we either have to readdress medical education, or at our health center, we're working in collaboration with substance abuse counselors right on site, and we're screening most of our patients for substance abuse, and we do an immediate referral. So at least if we don't have the skills to do it, we can collaborate with those who do.
Okay, let's bring everyone back into the table, and while we do that, we'll go back to social media and we'll come back and continue this conversation. We're just going to keep the conversation going, but Dr. Miller, tell me what you were just sharing there about young doctors and their choice whether or not to go into primary care.
So most of us have inadequate training in how to address substance abuse. So when someone comes and they are doctor shopping, it's very stressful for the physician, especially a young physician, if you don't have the skills to deal with it. And I have learned a lot just on my own since my training. But during that training, the only thing I learned was how to finally identify someone who was abusing my prescriptions and how to discharge them from practice. And yet, we really need to know how to help these patients. So I was really saddened in talking to a number of doctors in training. I was giving a mentorship talk to about 30 residents in internal medicine, and I asked them what would make them hesitate becoming a primary care provider. And as you know, we have a shortage in primary care providers. And a third of them said that a major reason, and these are residents training in Missouri, a major reason why they wouldn't want to go into primary care is because of all the narcotic seekers.
And is that Missouri specific? Are people coming from other states because of the availability?
Yes, absolutely. And with us being in the Boot Hill, we're Tennessee, Kentucky, Illinois, Arkansas. They're right there. And I have a pharmacist who is also a drug task force, and he has arrested someone in his pharmacy before coming across the state line doctor shopping.
You're seeing
Absolutely. We've seen this constantly. And I think one of the reasons is you don't have a system here. We become a little attractive here in Missouri.
We have 8 states on the border.
And you have multiple states on a border. And we've seen people from as far away as Maryland going to ostensibly to a physician in Georgia and then driving to Missouri to fill that prescription, which just seems a little bizarre given the amount of pain that these people claim to be in.
Missouri isn't the only problem, though. I think I got this number from Dan years ago. The United States represents 5% of the world's population, yet we consume 99% of all the Vicodin produced for the planet. We have a huge prescription pain problem in the whole country. Granted, Missouri's getting the car cheaper right now without PDMP, but this is a bigger, major issue that needs to be looked at because of that number.
We see a lot of stats like that. I mean, we do the most polluting, we eat the most whatever. But I mean, but do you? But I want to pick up on what you're talking about there. What is our attitude? You mentioned the evolution of prescription drugs. What is our attitude?
Well, a pill will fix anything. And we have to get away from that. I mean, there's a lot of reasons for a lot of great medications helping people, certainly. But we have to recognize when there's a huge downside like this and young people are dying, we have to respond to this. And we can't just keep throwing out statistics and talking about it. We have to take action. So it's policy, it's community education, it's prevention for youth. That's a huge issue that's missing, that we have to do more for kids to prepare them to make good choices for themselves. And we have to have good treatment available when people do get caught up with an addiction. So we need all those things.
Available is the biggest word. Treatment availability, which is almost non-existent for people without insurance, have to go to great lengths to get help, which is a tragedy of this country, that they can't get help.
Let me just say we're going to continue this conversation online. Stay tuned, 9net.org. Find us there. We're going to be live there, but for now we're going to say goodbye on the air. Thank you, folks. Daryl, we started the show with you. You've had a little time to kind of sit back and watch what we're doing here. Tell me what's on your mind.
Well, I think one thing that we haven't talked a little bit too much about is mental health. And I think that's one of the things that we have to be cognizant of. And I think that's another issue that primary care physicians don't get a ton of training about. I know there's a lot of reticence to talk about mental health and the stigma attached to it. But I think that's an issue that could probably be brought up a little bit, especially with the stigma and things like that associated with it.
In treatment, we find at Bridgeway about 7 out of 10 clients that come in for substance abuse treatment also have comorbidity. And interestingly enough, with adolescents, that number actually seems to be also on an uptick. And I don't know if that's because people are diagnosing better or there's just more prevalence to it, but as it relates to substance abuse, when you find something that's at 70, 80% of the time, that's definitely something that needs to be addressed. I think the treatment of it has improved. Chad was speaking to it a little bit, and Karen definitely spoke about it earlier. But the Children's Service Fund and all of these providers are providing treatment to adolescents here in St. Louis County. And what's so important about that is it needs to be solution-based. We can talk about it from a criminal justice perspective, or that somebody is wrong, or the stigma that's associated with it. Once it becomes public health policy, that stigma can just, when I was thinking over there was, when a person gets diagnosed with cancer, the immediate conversation becomes treatment and only treatment until that treatment works. That is not the case as it relates to chemical dependency or mental health issues. It relates then to a stigma that's associated with it. There's something wrong with that person, and then the symptoms are what gets focused on, not the solution. So the solution for chemical dependency specifically is treatment. For abuse, I would say education or prevention, but also treatment for that as well.
I would add that even before treatment is screening. And there is so much time invested in screening people for their cholesterol level. And everybody even knows what their cholesterol level is or how often they're supposed to check their cholesterol. But who cares what the cholesterol level is if they're addicted to alcohol or opioid pain meds?
I mean, I have a disease that you can't detect. It's like a peanut allergy. Until I take pain medication irresponsibly, become addicted to it, whatever is my path, that's when I'm going to cross the line from abuse into addiction. So it's kind of hard to catch that before it starts. Prevention, education, solution once that happens, but there's no real way to predict when and who is it going to happen to.
So we have a screening tool called SBIRT, which is screening, brief intervention, and referral to treatment, but it's going to miss a lot of folks. And so I've been fully trained in practice for 11 years, and the times in which I have missed something or I have been burned, I have not served a patient, is when I miss substance abuse. And I go back and I look at that first note, and I definitely asked. I asked a really good med student history, and they said no. And it's only as a maturing physician that I realized that it's only after they trust me for a few years that you ask and you ask again.
And it's hard too. I think pharmacists can be a step in that to catch that early, but again, we don't have the monitoring. And so is this prescription from across the river in Illinois or Kentucky legitimate, and they're here visiting a family, which could be very legitimate, and you don't want to refuse pain medication to somebody who really needs it. But as a pharmacist in the pharmacy, we don't have that network and that ability and to notify the physicians and to really have that teamwork approach to addressing this early before it becomes a bigger problem.
Just one back to what you just said. The reason why it takes me time to trust you to answer that question correctly is because I have been taught since a very young age that since I'm addicted to drugs, there's something wrong with me. If you ask that same standard medical question for a cancer, diabetes screening, you're going to get a straightforward answer right off the bat. It's going to take years of trust for me to actually admit to you, yeah, I have a problem. That's because in my brain, because of what has happened in my life and what I've seen on television, what Dare taught me, things that I do drugs, I'm a bad person. That is what is killing people and also needs to change. We need to remove that from the society. I mean, it's an impossible task, but we have to try something because it's killing people.
I lie to you about how much I even exercise. So. It's not 3 to 4 times a week.
Maybe I was a little
more of a goal.
More of a guideline.
What I'd like to be doing, not what I am. Yeah.
This end of the table often gets shut out by the ergonomics of design here. Joe, what should I have asked you over there? What's on your mind?
Oh, I just think people need to realize that in today's heroin world, they don't realize what they're getting. Kids have no idea what they're getting. They're getting it in a pill form. They're still ingesting it, or they're using it as a needle. But the heroin purity today is 90%. Back in the 60s and 70s, it was 10, 12%. It's so much stronger now, and these kids have no idea what this is doing to them.
And we didn't really talk about it tonight, but that's how people overdose. Is that right? I mean, because it's different. Like one particular amount got a particular amount of high one time, and that same amount, if it's cut differently or have a different purity, could kill you.
And what is happening is these kids are trying it, and they're getting that big shot from the dealer. Then when he starts cutting it, they start realizing what's going on, so they go find a new dealer. The new dealer gives them a big shot again, and boom. It's attacking the respiratory system, and they're just shutting down. And my son was 90 days clean when he relapsed.
Let's talk about that. It's where I want to know, and maybe you can help us here, the status of something like Narcan and the PDHP. Did I get the acronym right? PDMP, sorry.
The status of Narcan, from what I understand last week, is that it's dead for this year. We have 2 weeks.
No, Narcan actually passed out
Just
the Senate
yesterday.
last night.
Yes.
Oh, did it?
Yes, it
Well,
came out of the Senate last night. Currently, it's on its way to Nixon's desk.
I wish we had a reporter here who would
No, it was. Right. This was already.
Yeah, no, you're right.
Yeah.
The Senate,
passed out.
that is correct.
Yeah,
I saw that
It
today.
passed out last night. This is for first responder Narcan. So what this is going to mean is that ambulance usually carry it, but firefighters, police are usually the first to arrive on the scene. So they're going to be able. This law.
I know that our county chief has spoken out in favor of.
No, he has. Now, what this law is going to do is going to give them the ability to carry Narcan. It's not going to require them to do it. So there's a difference between getting a law passed and implementation. So when and if Nixon signs this into law, the next step will be all of us and people in the community getting together to ask that their first responders start carrying Narcan. And this is just a piece, as we said earlier, of the harm reduction picture, which includes Narcan, 9/11 Good Sam, PDMP, other things to try to give people the most access to staying alive until they're ready to get help.
The 9/11 your reference you there is if you call someone's overdosing, you're not putting yourself at risk of prosecution.
Correct. You'll get limited immunity from prosecution for small amounts of possession. That bill actually died this year. We'll be revisiting that next year in Jefferson City.
Okay.
One thing seems clear tonight, I mean, from all these conversations, everybody's here, we all seem to be on the same page with the PDMP, that we've got to have this in this state. And so the challenge is, as I mentioned earlier, and I mentioned the senator by name for a reason. We've got this one obstructionist, and what are we going to do about him? You know, how are we going to get past this one senator who's filibustering and stopping this bill, this law that we need in this state?
Any chance of that happening this legislative session?
Well, I think that there still is. We have 2 weeks left, and you know, and by all appearances, it's sitting in committee and is not going to come out in the Senate. However, we've been contacted by a New York Times reporter a couple of weeks ago. He actually showed up at the Capitol Monday, interviewed Dr. Schaaf, doing a very big story on Missouri, and he's down in the Boot Hill today meeting with doctor shoppers and folks that are addicted, and is going to try to bring light in the United States of what Missouri is lacking, and it's shameful. And I think that we need to get that word out, and he's going to help with that. And he's very fair. He's interviewing people on both sides of this, and gave Dr. Schaaf a very nice interview, and let him speak his piece about the privacy issue. I don't feel it's a privacy issue because, as the doctor mentioned, this information is out there. It's just in different locations. We just don't have the access to be able to be preventative of this.
And we're not getting reports from the other 49 states of abuses of this either. And I think that's a heavy indicator of the fact that it makes sense for Missouri also.
Yes.